Today we have the pleasure of hearing from Dr. Misiukiewicz, Associate Professor in Hematology and Medical Oncology. Dr. Misiukiewicz attended medical school in Poland, followed by internal medicine residency at St. Barnabas, and then Hem-Onc fellowship here at Mount Sinai. His clinical work and research focus on head and neck cancers, and he has published extensively on the treatment of these diseases. He also serves as the clinical director of the Center for Personalized Cancer Therapeutics here at Mount Sinai. Please join me in welcoming Dr. Misiukiewicz.
So good morning, everybody. My name is kind of complicated, and there are many variations how they call me. Some patients, they call me Dr. Christmas. I like it too, but my favorite is Dr. M, like the one from James Bond. So you can call me any way you want. And if you're trying to email me, you have to put your both hands on the keyboard. My name will come up, I promise you. So that's that. So I'm going to be talking about head and neck cancer, but I decided to focus on HPV because it's sort of like a hot topic right now, and we see some change in the epidemiology. So I'm going to be covering the biologic principles, changing paradigms, epidemiology, and this is going to be primarily the focus of my talk. So those are my disclosures. So when we think about head and neck cancer, many times we divide the head and neck cancer based on the location. So we think about nasopharynx, oropharynx, laryngeal cancer. But I want to divide this cancer in two distinct subtypes based on the completely different criteria. And it's going to be HPV related cancer and environmental related cancer that kind of covers the smoking related cancer. And they're drastically different. So when we think about the HPV-related cancer, it's caused by high-risk HPV. So as you know, there are many subtypes of HPV. Some of them are considered high risk. And 90% of those patients, they are HPV-16 positive. They're driven by the viral oncogene, so this is what we know. They're highly restricted to oropharynx. So actually, oropharynx is sort of like the back of your throat. So it covers the base of the tongue and the tonsillar area. So actually, we don't see HPV cancer in the tip of the tongue, the side of the tongue, in the buccal area. It's primarily in the oropharynx, and it can be because even if you're going to do your own experiment, you're going to look at the back of your tongue. The structure of the tongue in the back is completely different. It's covered by the lymphatic tissue. They have distinct molecular markers. They have good prognosis. This is something that we know. And most of the time, those patients are very young. They're drastically younger than the typical patient that we see. So actually, as of now, we also see patients in their like late 20s. It used to be like 30s, 40s. So there is a drastic change. When it comes to environmentally related cancers, obviously they're caused by smoking and alcohol. They have this field effect. So they happen throughout the oral mucosa, and obviously most of us, there were some presidents that didn't inhale, but as you inhale, obviously there's a field effect. They have distinct molecular markers, they have poor prognosis, and there is a risk of developing second cancer. So why it's so important? Because we see a drastic change in the incidence. So on the left side, as you see that in the early 80s up to like early 2000s, the incidence of the oropharyngeal cancers kind of stayed the same, and it was primarily because the HPV negative cancers, the incidence goes down, but at the same time the HPV positive oropharyngeal cancer kind of goes up, so it kind of compensates for the drop. As you see in the middle slides, that we know that HPV is linked not just to the oropharyngeal cancer. We are completely aware that it can cause cervical cancer, it can cause anal cancer, it can cause penile cancer. There are many others. And obviously, cervical cancer was dominant kind of in the 80s and 90s, and the incidence was pretty high. But as we see now, the incidence started going down, and it's probably because of the Pap Smear and the early detection and the treatment. But as the cervical cancer goes down, the incidence goes down, we see the sudden increase in the oropharyngeal cancer, and it's predominantly in males. And it's projected that, as you see on the far left, that obviously this incidence is going to continuously to go up. So yes, it's a very alarming, and obviously there are some strategies that we have to kind of put in place to kind of change this. So what do we know about the HPV virus? So obviously there are hundreds of them, and we can divide them in the low risk and the high risk, and obviously we're going to be focusing on the high risk. So it's a double-stranded DNA virus. Only one strand is coding. There are two types of proteins. There are late region proteins, L1, L2, and these are responsible for encapsulation of the virus. And then we have the early region proteins that are responsible for the viral replication and integration of the viral DNA into the human DNA and then subsequently to carcinogenesis. Why it's so important? Because as of now we have preventive vaccines such as Gardasil, and those are based on the L1, L2. They help obviously the human being obviously to protect them from virus entering the body, and obviously we have therapeutic vaccines that are not used yet, and obviously the therapeutic value is based on the E7 and EC protein. So those two proteins, E6 and E7, obviously are responsible for carcinogenesis, and the way they work, there are two proteins in the human body. One is called P53. So P53 is sort of like a security guard. So basically what it does, it makes sure that if there is any abnormality in the DNA, if there is any accumulation of the mutation, P53 stops the cell division. So we have to kind of fix the DNA before it's going to be moved on. So with the E6 viral protein, what it does, basically, it binds the protein and becomes inactive. So there is no check. So what happens subsequently, there is accumulation, probably accumulation of the mutation, and subsequently it can lead to the carcinogenesis. And E7 protein has a kind of a similar mechanism, but with the different protein is the retinoblastoma tumor. And both of them are suppressors proteins, and they lead to the carcinogenesis. So this is kind of the typical picture that I see. This is the CT scan of the neck. So the arrow kind of points to the left side. It's a tonsillar area, so we see there is some enlargement. And next to it, we see like a huge cystic lymph node. So this is kind of a typical presentation, and this is something that we see as those patients, they come in. So I know that in the audience, we don't have many hematologists and oncologists. I'm not going to be talking about mechanisms of action, and kind of get into details of oncology. I just want you to see the trends. I'm going to be kind of giving you the very generic discussion about how those people are treated. So the first study that kind of put the HPV on the map, it was the ECOG study, 2399. And what they did, they gave chemotherapy, and we don't have to really spend too much time why they used the carboplatin and paclitaxel. Basically, they gave chemotherapy, followed by the chemotherapy and radiation, and at that time it was considered a standard. It was a 70 grade of radiation, and they gave Taxol weekly. And the study included patients with oropharyngeal cancer and laryngeal cancer. And obviously from the previous slide, we know that we shouldn't be seeing any HPV virus in the laryngeal cancer. And this is the patient characteristics, oropharyngeal cancer, OP. There were about 60-something patients, 38 that were HPV positive, and 24 that were HPV negative. And obviously, naturally, we don't see any HPV positive patients in the laryngeal group. So 60% of the patients within the oropharyngeal group, there were HPV positive. But what was interesting in the study, they realized that the survival curve there were drastically different as you're going to stratify them based on the HPV positivity. So you see this wide separation of the curves. So it was very thought-provoking and obviously led to subsequent studies and tremendous interest in the HPV positive cancers. Obviously, the second question that was asked, obviously, where this benefit comes from. So the benefit comes from the local regional control. So LRF is a local regional failure, so we see 2 patients failing in the HPV positive group, and we see 8 patients failing in the HPV negative group. So the benefit comes from the local regional control. So having this in mind, so now we kind of know that we have a cancer, we have different strategies, and we know the HPV positive patients, they do significantly better than HPV negative. And the strategies that we use in head and neck, this is surgery, radiation, and chemotherapy. So the question now becomes, using those different strategies, these patients are going to perform the same way or not? So Italian group, what they did, they took HPV positive patients, and they treated them as per standard of care with surgery, and some of them require radiation. So if it's a small cancer, we just do surgery. If it's a larger cancer, we do surgery followed by the radiation. And as you see, the blue curve represents the HPV positive patient. They didn't require radiation. And the gray curve represents the patient that were HPV negative, but also didn't require radiation. So it was kind of the same group of patients. The only difference between those two groups, they were treated exactly the same way, but the difference was that some of them were HPV positive and some of them were HPV negative. So obviously the conclusion is, it doesn't matter what tool you're going to use, HPV positive patients are going to do better. And we see the same trend in group of patients that received radiation, so the yellow and the red. So the conclusion was that obviously, even if you're going to do surgery for those patients, HPV positive patients are going to do significantly better than HPV negative patients. So the second question was, okay, radiation guys, they said, what about if we're going to do our treatment, which is radiation, and we're going to stratify the patient based on the HPV positivity, and we see kind of the same trend. So we see that obviously HPV positive patients, if you're going to use radiation only for appropriately selected patients, HPV positive patients, they do significantly better. And then there is third, there's a TAX 324 study. In this study, we use chemotherapy and radiation, and we see the same trend. So the conclusion was, it doesn't matter what treatment we're going to use, those patients, they do better. There's something in this disease and the biology of this cancer that obviously the survival is favorable for those patients. So now the question is, as of now, we treat patients with HPV positive cancer and HPV negative the same way, even though the survival is significantly different. So obviously the question now becomes, should we give them less? And obviously this is something that we don't hear often in oncology. I don't know if you guys read the history of Maladiv, the Emperor of Maladiv. So, it goes through the history, how those people that were undergoing surgery were kind of resecting more and more. And all of a sudden, the question is, should we give them less? And why we should give them less? I mean, the reason for this is that what we see in head and neck cancer patients, those patients, they have acute toxicity and they have delayed toxicity. And obviously, acute toxicity kind of happens at the time of the treatment. It is important, but it's not as important because it kind of comes and goes. Those patients are going to do better. But what you're really concerned about is a late toxicity, something that the patients are going to be stuck for the rest of their life. And what we do see in patients who are treated with head and neck, obviously, is the PAC-DUP dependence, dysphagia, odynophagia, problems with speech. So those are very important, obviously, factors when we consider the quality of life. And as you see, in 3 studies done by RTOG, 43% of the patients, they had some problems. So obviously, it is an ongoing problem, and obviously, we should kind of address it. The second question is, whenever I have a patient, and we have some clinical trials, some studies, when we offer them less, the second question is, that the patients, they ask, if I'm going to get less, will it compromise my outcome? And obviously, this is something as a doctor I have to ask if I want to kind of take the risk. And the second, if the patients are willing to do it. So there was a survey, and some patients, they said, 35% of the patients, they said, we don't accept any change in survival. It's totally unacceptable. And 34% of the patients, they said, I will be okay with the 5% drop in survival as long as I'm going to be subjected to less toxicity. And now, the last question is, obviously we have very difficult group of doctors. So we have surgeons, they can be very tough. We have medical oncologists and we have radiation oncologists. And the question is, who will compromise? Which part of the treatment we should eliminate or we should reduce, and we want to feel important. So obviously, none of them obviously is willing to do it. So should we eliminate the surgery? And when I think about elimination of the surgery, like should we operate on the primary mass and leave the lymph nodes? Should we remove the lymph nodes but leave the primary mass? Should we go down on the radiation dose? Should we eliminate the radiation? Should we eliminate the chemotherapy? All of them, any kind of constellation is possible, and the question is how we should do it. So some of those studies, they claim that obviously they de-escalating the treatment, meaning that we're going to give less. And obviously the first study that I want to present is called De-Escalate HPV. And I don't want you to think too much about how it was done. What I'm going to say that both arms, the P100 and XRT versus Erbitux and XRT, those are standard arms. There is no de-escalation. This is kind of the phase 3 study asking which treatment is better with the HPV positive patient. So the name is kind of misleading. Probably the authors thought that now we kind of having chemotherapy that we use in oncology, and we have targeted therapy. And targeted therapy, in theory, this is sort of like we're supposed to target the cancer, and we're going to be sparing the patient from toxicity because it's so sophisticated and targeted. And Erbitux is such a drug, it's the HFR inhibitor. So in this study, they were just comparing two standard arms. There is no de-escalation. And it was surprising and shocking that everybody was expecting that the target therapy is going to perform better, but the old-fashioned cisplatin actually was better. So there was a change in the survival, and it was statistically significant. So we shouldn't be changing our paradigm, and still we should be using chemotherapy. But there is no de-escalation. So second attempt was, and it's slightly different. So in both arms, they were giving the same dose of radiation with some change in the fractionation, and patients were randomized to the lower dose of cisplatin versus the standard dose of Erbitux. And the question was, which arm is going to perform better? And there is not so much about the de-escalation. The only thing that was de-escalated patients in the upper arm, they were getting the lower dose of chemotherapy. And again, even though the dose was reduced, cisplatin performed better. So there was a change in the overall survival. It was 85 versus 78% at 5 years. So, and again, cisplatin proved to be better. And it was kind of carried into the local regional failure. There was a trend. It was statistically significant in favor of cisplatin. So subsequently, we go to another attempt, and this time actually patients, they received lower dose. So the standard dose of radiation is 7,000 gray, and patients with oropharyngeal cancer were randomized to two standard arms, and they were compared to the historic data. So the first arm, which is the arm 1, patient received lower dose of radiation with weekly cisplatin, and the arm 2, it was radiation only, but with no chemotherapy. And the question was sort of like, what should we de-escalate? Because obviously we have those strategies such as chemotherapy, radiation, the surgery. So which of them should compromise? And as we see, after a median follow-up of 2.6 years, the 2-year progression-free survival for the arm with chemotherapy rejected the null hypothesis, and the PFS was 90%, and unfortunately the radiation-only arm, it was unable to reject the null hypothesis, kind of suggesting that the chemotherapy is an important piece of the treatment as we're thinking about the de-escalation. And again, it was carried to the local regional failure, similar results, and there was no difference in overall survival. So, and obviously there is always a question when we think about de-escalation, what is the benefit? Because obviously the benefit is from the decreased toxicity. And the difference in toxicity between those two arms was mainly in the cytopenias. There is some difference in dysphagia, as we see. There is no difference in mucositis. There is some difference in dehydration and weight loss, but it was not really significant. But the main difference came from addition of chemotherapy, came from the cytopenias, and this is something that can be easily addressed. So that was kind of the first part as we think about the de-escalation. The first study that actually asked this question properly, it was the ECOG study, when the patients received oropharyngeal cancer HPV positive. They included smokers in the study. They received chemotherapy, and they were subsequently randomized to the lower dose of chemotherapy and radiation, which was 54 gray versus the standard. So this is the first kind of study comparing standard fractionation, standard radiation versus the lower dose, and obviously there is going to be any difference. And actually what was really surprising that the lower dose of radiation performed better than the standard dose, as we see the 2-year progression-free survival was 65% and the lower dose was 80%. And the similar result were carried to overall survival in the favor of low dose of radiation. But it's not just as we think about de-escalation that we should just make a decision to kind of put everybody on the study as long as you're going to be HPV positive. You have to be a little bit more sophisticated. So actually in the low dose radiation arm, there were about 11 failures, and as you're going to see, most of those patients, they were heavy smokers. It was like at least 10 to 20, some of them were like more than 40 pack-year smoking history. So the question now becomes, should we and especially in obviously in New York City, should we subject those patients obviously to lower dose of any kind of form of the treatment because maybe the outcome is not going to be as favorable. So we know that the smoking history obviously is an important factor, and obviously the other bad prognostic features are kind of suggesting that those patients are going to have the higher chance of failure at T4 and N2C. So we should kind of make the selection criteria more strict. And when they did the analysis based on the smoking history, all of a sudden you see a significant difference. The 1-year progression-free survival based on the smoking history, and the cutoff was 10-pack year, it was 97 versus 84. And the patients that were more advanced, they had the N2B lymph nodes, the pattern was the same. So obviously this kind of proves the point that obviously smoking history compromised the favorable prognosis of those patients. So what do we do at Sinai? Having all this, we kind of decided what we can do, because obviously you want to change the history, you want to change the paradigms. And as I mentioned, as of now, we cannot give our patients lower dose of radiation. We cannot give them less. And obviously, I always kind of try to be funny. I don't want to be called by Jacoby in the middle of the night if I'm going to be giving less, because it would be considered suboptimal. Even though patients, they ask about this, the only way to do it, obviously, you have to have the proper trial. So we have a clinical trial for non-resectable patients, and what we decided to do, that we were giving those patients a chemotherapy. It was dose reduced, and if you respond, we'll randomize those patients to the standard dose of chemotherapy and radiation versus the lower dose of chemotherapy and radiation, which was a 7,000 gray versus 5,600. And obviously we wanted to see if there is any change in survival, if we're compromising it, what is the benefit of giving them lower dose of radiation. So initially in the study we have, in this report we have about 20 patients. So the standard dose, it was a 2-to-1 randomization. That's why we see more patients in the reduced dose of radiation. So we had 12 patients on the reduced dose, 8 patients on the standard dose. And obviously those are the patient characteristics. There were some T4 patients on the standard dose. But the survival after 4-year follow-up, the PFS was 87% versus 83. So kind of the conclusion is that, that obviously no matter if you're going to give the high dose or low dose radiation, the survival is going to be in the same range. And actually we have the update, and this is just for the lower dose of radiation. This is 4-year follow-up. So the progression-free survival for those patients is 84, local regional control is 88, and distant metastases is 97%. So all those patients, they do quite well. And this is kind of the question that we always ask when we have those patients coming. So if I'm going to be on this trial, what about other patients on the study? How did they do? And actually, they did pretty well. So we have one study that kind of covers the non-operable patients, but the question is, obviously, what we can do, how we can de-escalate the treatment for surgical patients. And it's kind of a tough task. I don't know if you ever had to do any clinical study with surgeons. This is kind of a tough crowd to do it. So I don't know, it's like lots of negotiations. And again, they have the point that the one of the problem is they want to operate quickly. They want to kind of put the patient on the operating table. And all of a sudden we tell them, there's a patient who has to sign the consent. It takes time. You have to go through the exclusion and inclusion criteria. It takes some time. You have to check for the HPV testing. It takes some time. And here is this patient who you want to operate on. But we are pretty successful. So our ENT team was very receptive, and we were able to do this study. So basically, this is pretty interesting study because there is no randomization. So you cannot randomize the patients in the surgical world, like who's going to get the operation, who's not going to be the operation. And all those patients, they underwent TORS. TORS is a robotic surgery. So resectable patients, they underwent TORS, and based on the pathology report, they were stratified to different groups. And we don't really have to go through the very detailed characteristics. So basically, some of those patients, they have a favorable prognosis. Some of them, they have a little bit less favorable prognosis. But all of them were de-escalated. So the first group, for example, many of those patients, they would undergo radiation, but we were just watching them. So you can imagine, as of now, we just do the surgery and we do nothing after. For the group 2 and 3, those are, for group 2 is the intermediate risk. We do radiation only, but we give them the lower dose. The standard dose would be about 6,600 gray. Group 3A and 3B, those are the high risk, and those patients that would get chemotherapy and radiation, and the chemotherapy and radiation would be between 6,600 gray to 7,000 gray, so the dose would be significantly higher, and obviously in this group, the dose is significantly lower. And the question is, how did they do? Whenever we have a patient that we want to do less, and let's say some of those patients are going to fail, the question is, can we still rescue them? So what's really important that we do see about 4 failures, and it's 2 failures in the first group. This is the group of patients that received nothing after the surgery. And we have 1 failure in the intermediate group and 1 failure in the advanced group. But all of them were salvaged. So they're still alive, so obviously this is very encouraging. And obviously the PFS, disease-specific survival and overall survival, it looks very promising. So obviously we're hoping this study is going to change the paradigm. It's going to change the clinical practice, that we're going to be able to give them less treatment. So as we kind of pushing the envelope, in our study we were giving 5,000 gray or 56. There are some other groups, they're trying to push the envelope even more. So what they were doing, that they decided to go down the radiation dose, and it was 30 gray, but in order to compensate for this, they were just giving them chemotherapy. So you go down on the dose of radiation, but at the same time you're giving them chemotherapy for the good prognosis and kind of the advanced prognosis, or maybe not bad prognosis, cohort A and cohort B, and just to see how those patients are going to do. And obviously the good ones, the ones that in our studies they undergo surveillance, the survival is 94%, so it's very good. So the question is, what should we do? Should we do our approach, just surgery only, and just surveillance, or we should just give surgery and the lower dose of the chemotherapy and radiation? Obviously, this is kind of the ongoing question, and this is kind of part of the problem, that we don't have one uniform kind of approach as we treat those patients, and when we do those studies, it's going to possibly create very different paradigms. But the cohort B patients, the survival all of a sudden drops. So maybe going down on the dose to 30 gray, it's not the way to go, but obviously this is the ongoing question. And there is another study that it's done by ECOG, and it's actually completed, and it's very similar to our surgical studies. And the reason that I'm presenting this, there are so many different studies, and the question is going to be what's going to become a standard of care in this large number of different studies. And the last one that I'm going to present, that I'm sure that you heard there is something new in oncology. We use immunotherapy. So now the question is, as we kind of going down on the dose, how are we going to incorporate immunotherapy to this process? And it's kind of a tough question, because if you have studies that are ongoing right now, and we're using chemotherapy, and we don't have any studies showing that immunotherapy is better than chemotherapy and those settings, in all the patients, should we incorporate into de-escalation? Should we kind of do the double question? Go down on the dose, but at the same time use the drug that we don't even know if it's effective. So they're trying to answer this question in this study. So they have 3 arms. The first one is standard, and there are 2 experimental arms. One of them is with chemotherapy and radiation. The other one is with nivo and radiation. And based on the, let's call it the contest, the winner of the experimental arm is going to be used in the phase 3 study, and obviously with hopes to create a new paradigm. So to kind of summarize this, should we de-escalate? Should we go down on the dose? And I think we should. This is something that we should do. And we know it from the history of in oncology. We have patients with Hodgkin disease that we used to treat with this very intense chemotherapy regimen that kind of led to the cardiac problems. We have breast cancer patients that obviously they have some problems with heart as a consequence of the treatment that we give. So definitely we should. But it's not as easy. It's not just let's go down the dose and see what happens. Obviously, we have to decide on the dose. We have to decide, obviously, on the selection criteria. And obviously, there are some important factors such as smoking history, extracapsular extension, T4, contralateral nodes, matted nodes. And there are many kind of questions that obviously we have to answer if all of them should be used in the selection process. One thing that in this battle that we all agreed that, and I mentioned two kind of three strategies. I mentioned chemotherapy, radiation, and the surgery. The main toxicity, and I hope that we don't have the radiation guys here, they're not going to take offense of this. The main late toxicity comes from the radiation. So, and it's not just the dose, it's the field. The field is like how much you're going to radiate, right? Obviously, you're going to expose patient to the radiation. The second is the dose, and this is something that we should really explore. So at Sinai, we have kind of benefit because obviously as we're asking those questions and we're trying to answer them, obviously we have access to TORS, we have access to robotic surgery that we use our surgeons. We have a trial for this, so we are trying to answer this question. We have the reduced radiotherapy for the surgical patient and non-operable patients. We have clinical trial for patients that require chemotherapy. But also we have the access to the proton facility. So actually now we just built this huge facility on 126, and the question is by changing regular radiation to the proton radiation, if it's going to have an impact in this. And obviously the last question is, what is the role of immunotherapy? So what's on the horizon? Obviously I mentioned immunotherapy. We use PD-1 inhibitors, obviously in head and neck cancer. The question is how we're going to incorporate them into the de-escalation process. We have multiple vaccines. I don't know if you know, but the Gardasil was just approved, and it extended the age, right? The age cutoff. It used to be 26, now it's 45. So if you have a patient who's 44, actually they can get a vaccine. And the rationale is even if you're sexually active, because vaccine not only covers for the HPV-16, it can cover for the other viruses, so you can get protection from this. So if somebody's 45 and below, so I would still encourage, obviously, for those patients to be vaccinated. We do have therapeutic vaccines, but they're not commercially available. Those that we use in our practice in oncology, those are the vaccines to kind of help us how to treat the patient that already was exposed to the virus, and obviously how this treatment can kind of help those patients to battle the cancer. And obviously there are some biomarkers. Obviously the circulated DNA, so we can kind of measure how much DNA or viral DNA you can have in your blood. So obviously those are the kind of the tools that we can be using. And to kind of the final remarks, obviously HPV oropharyngeal cancer is a concern because obviously there is an increase in incidence. It's projected that about 30,000 cases are going to be present in the United States in 2025. The population is evolving, so obviously we see less smokers, but we see more patients obviously having the HPV-positive cancers. Those patients, they do well, so probably at some point, no matter what you're going to do, you may see them because they're going to be surviving the cancer. And I'm hoping they're not going to be subject to any kind of delayed toxicity or late toxicity. No matter what you're going to use, as of now, surgery, radiotherapy, or chemotherapy, all of them are highly effective. The question is how we're going to de-escalate, and obviously this is the ongoing question. Actually, I was kind of contemplating, I have some kind of difficult question that I'm asked, and it can have some implication for you. And you would be surprised, I'm emailed so many different questions. Some of them are very controversial when it comes to the HPV, and for some we do have the answer, for some of them we don't. And actually I may decide to present them. Many questions that I'm asking and be important for you in clinical practice. The first, how did I get the oral HPV vaccine? And this is the question that the patient they ask, the spouses they ask, and actually we don't know precisely how. And obviously probably it's a sexually transmitted disease. The problem is with the sexual activity, all those activities are kind of collinear. People, they kiss and do other things at the same time, so it's hard to say which of those behaviors kind of leads to infection, but definitely it's a sexually transmitted disease. The second question, the HPV oropharyngeal cancer caused by oral sex, we don't know, and probably yes, based on the epidemiology, but we don't know. How did I get the oral HPV infection? So it's yes, it's a sexually transmitted disease. And this is the other question that I'm being asked, and many times what happens, and this is something that you're going to be obviously exposed to, you have to counsel them, that there are many assumptions. I mean, there are many patients that come, I mean, I have a couple that are coming in, one of the spouses diagnosed the HPV cancer, and obviously the question is about fidelity, and obviously I always tell them it's not about the recent events, it's not being the promiscuous, it takes about 13 to 15 years from exposure to development of the cancer, so it's not about the recent events. So obviously this is something that you have to kind of keep it in mind. There's something that applies to us, obviously how you can get it. Kiss, sharing a spoon, going to the restaurant, can I get infected? The question becomes for the family members. This is something that I deal with, for the patient who is just diagnosed, how can I transmit to my family members, to my kids? I mean, by kissing them, should I kind of withdraw myself from kind of being a father, or even sharing a spoon? And actually, incidental transmission via the spoon is not really reported, so probably not. When it comes to kiss, and obviously it's a different type of kiss, obviously when it comes to the kids and versus to your spouse, there is lots of controversy if by kissing you can transmit this disease. Obviously the question is, my partner has the HPV-positive cancer, what should I do? Many times what happens when you treat those patients, you can eliminate the virus along with the cancer. There are some patients that unfortunately after the treatment they still have the virus present. And obviously the question is what kind of strategies you can kind of do. And I say nothing. Whatever happened, happened. Obviously, you already were intimate, so if you exchange some kind of the virus, it already happened. There is no ramification for you. The other question is, can I do a Pap smear? So the Pap smear can be done, but obviously not in the oropharyngeal area, just because it's a completely different environment. It's not sterile. As you know, the lymph nodes, they have many pockets, so it's almost impossible to scrape those cells, and it's not going to be very accurate. And I do get emails about this. The other question is role of tonsillectomy. So obviously, if there is any preventive measure, something that I can do to obviously to kind of protect me for any reasons. And obviously, the problem is that oropharyngeal cancer is not just the tonsil, it's the base of the tongue. So it's like, what's the point of removing the tonsil and leaving the base of the tongue? It's sort of like for skin cancer, cutting both ears and leaving the forehead. It's like, it doesn't make sense, so there is no role for this. And can the Hpv vaccine help? Absolutely. So I was like, for you guys, it's very important because obviously the vaccination, the rate of vaccination is not very high, and there are many kind of cultural problems because of this. So I want you to go home and say kind of, those people can be treated. We have something to offer at Sinai. I think the HPV is important, not just for us oncologists. I think it's important for you can be kind of faced with those questions. And I think we have to do the better job vaccinating those patients. So thank you very much.
So I'm used to the smoker presenting with head and neck cancer. How do these younger people often present? Because I imagine the presentation is different.
So yes, smokers usually it's a large primary mass and then not so large lymph nodes. People that's the HPV positive, so obviously they're young, they're predominantly male. So as you saw in my initial slides, it's kind of a typical for a guy, and they have pretty large lymph nodes. So, and obviously there is no Pap smears, there is no like early intervention, there is no screening. So most of the time it's a kind of a dental evaluation, it's an incidental finding. They report having some dysphagia. As the guys, when they shave, they kind of touch the neck, and all of a sudden they feel the lump. At the same time, on those notes, and that's why I kind of decided to present those controversial questions, because many times I'm being asked, it's like, there's some kind of an event in my life that I was subjected to the high-risk behavior. What should I do now? And obviously, there's nothing that we can do. It's like there is no Pap smear, there is no screening, there is nothing. So you have to kind of wait and watch those patients. Yes?
So, to add to your difficult questions,
Sure.
I'm wondering how many partners have actually both had HPV positive tumors, and did it turn out to be the same variant of the HPV?
Sure, so it's a good question. So there are two parts of the story. So we had a study, and what we did, it was in collaboration with Philadelphia, All of our HPV positive patients, we were doing a survey on the sexual behavior, and there was the oral rinse, and then we separated the partners, the spouses or partners, and they were just filling the survey about the sexual behavior, and we were doing kind of the equivalent of the Pap Smear, which was the mouth rinse, to see how many of those patients are going to have the HPV. And actually, the rate of having the HPV present in the spouses was low. Only one patient out of 64, it was a high-risk HPV, which kind of suggests that even if you're exposed to the virus, you're going to be able to clear the infection. But obviously there is not a clear answer. We don't know much details about this. There's actually, this is what I heard. I've never encountered this. I talked to Dr. Posner, who's actually my boss. So he said that he had a couple, and they had been married for a long, long time. So there is no kind of a sexual behavior on one part or the other. And actually they genetically tested and to see what's kind of a subtype of the HPV virus. It was exactly the same one. So, and it stayed within them. So probably yes.
Yeah, you showed the disconcerting predictions about the increased prevalence.
Mm-hmm.
I was wondering if you also model in the impact of the vaccine under different models.
Meaning like a preventive vaccine like Gardasil?
Right, so will we start to see the benefits of that? And
Is it
the 13-year,
It's a good question. So obviously, even for my personal career, it's like, should I stay in this field knowing that at some point? So this is what I would say, that obviously we know that we have significant challenges now, right? Vaccinating the kids or even grown-ups, because, there are many of them. So at some point, this is the hope, but there is no model to kind of see what's going to be the prediction down the line. I think there is some expectations of the vaccinations, right, that the rate's going to be much higher, and it's disappointing. So there is nothing like I'm aware of any kind of model to kind of make any prediction what's going to happen with the incidence.
It would seem that actually one of the single best arguments for the vaccine would be the models under different vaccine uptake.
True.
You would be able to actually look at the total public health burden of disease impact very clearly, and that might be a stimulus for uptake of the vaccine.
True.
That's what I was going to, Dr. Cespedes presented before, that the uptake in Australia has been completely different compared to here. So the educational initiative around the vaccine was very different. It was cancer prevention over there versus sexually transmitted disease over here. Is there any effort to change that educational initiative based on some of the rejections?
I think there is a provider problem and there is the recipient problem. I think we as a society, we as a doctors, sometimes we have a hard time to kind of put our personal beliefs on the side, so we have to do a better job educating the primary physician and pediatrician. I personally encounter, and I want to mention names, the doctors that were not really encouraging, for the vaccination of the kids, and the same problem is obviously the society, the public. Obviously, I think there is lots of stigma in this, and this is the main challenge. But so I think we have to do a better job educating.
So you seem to be suggesting that with question number 9, that does the vaccine help, that there might be some therapeutic benefit, or
No, it's preventive. So obviously,
in positive patients, would it have?
So I always believe that there's something kind of like a wake-up call. You always think that, whatever happened to other people will not happen to me, and all of a sudden you have a patient who has the HPV positive cancer. So this is kind of the moment. It's like, listen, we have kids. Maybe you should reconsider your initial approach. So yes, I think those preventive vaccine probably they're going to help. So yeah.
Thank you. One last question.
My question is about age. Age seems to be a big factor here.
Sure.
Do you or your colleagues study the cellular aging? I'm not talking about old people.
Mm-hmm.
Cellular aging phenomenon like Hayflick and so forth?
Nothing that I know of. No, I don't think so.
Thank you very much.
Thank you so much.